Let's listen to the next murmur, recorded at the third left intercostal space. This systolic ejection murmur, which is heard at the third left intercostal space, is typical of right ventricular outflow obstruction that occurs in Tetralogy of Fallot. Tetralogy of Fallot continues to be the most common cause of cyanotic congenital heart disease after infancy in the United States. Adults with unrepaired tetralogy may have symptoms of heart failure. In unrepaired Tetralogy of Fallot, the large ventricular septal defect does not produce a murmur because the pressures are equal in both ventricles. Listen once again to the murmur of right ventricular outflow obstruction as heard in Tetralogy of Fallot. What is unusual about this ejection murmur is that its intensity and duration are inversely related to the amount of obstruction. As the obstruction increases, the murmur becomes shorter, softer, and peaks in early systole, reflecting decreased flow through the pulmonary trunk. This is in direct contrast to the murmur of valvular pulmonic stenosis with an intact ventricular septum, where the murmur becomes louder and peaks later as the obstruction becomes worse. Compare the soft early peaking murmur of severe right ventricular outflow obstruction in Tetralogy of Fallot to the harsh late peaking murmur of severe valvular pulmonic stenosis. I will start with the murmur of right ventricular outflow obstruction and then add the murmur of valvular pulmonic stenosis. Over the last 3 decades, advances in surgical treatment have dramatically improved the survival of patients with Tetralogy of Fallot. Survival at 30 years has improved from 6% to 86% for patients with successful repair. Following repair, some patients may have a harsh systolic murmur at the lower left sternal border due to a residual ventricular septal defect. Listen to this example of a harsh pansystolic murmur at the fourth left intercostal space, characteristic of ventricular septal defect. Typical complete repair of Tetralogy of Fallot includes a patch closure of the ventricular septal defect, resection of the subpulmonic obstruction, and placement of the transannular patch across the pulmonary annulus. For many patients, this transannular patch results in significant pulmonic insufficiency. In addition, patients with repaired Tetralogy of Fallot may have a systolic murmur of residual subpulmonic stenosis as well. Listen to the murmur of mild subpulmonic stenosis and combined pulmonic insufficiency. I will start with normal heart sounds and then add the systolic murmur of subpulmonic stenosis, and finally a diastolic murmur of pulmonic insufficiency. It has been known for some time that patients with repaired Tetralogy of Fallot are at late risk for ventricular arrhythmias and sudden death. Sudden death accounts for 70% of late deaths in Tetralogy of Fallot. Over time, the pulmonic insufficiency may cause increased right ventricular size, right ventricular dysfunction, and increased QRS duration. Several studies have shown that when QRS duration reaches 180 milliseconds, patients are at a high risk of ventricular tachycardia. One group has demonstrated that pulmonic valve replacement in these high-risk patients leads to stabilization of the QRS duration. However, the optimal timing of pulmonic valve replacement is not yet established. Listen to the sounds of pulmonic insufficiency. I will start with normal heart sounds and then add the diastolic murmur of pulmonic insufficiency. In following adult patients with repaired Tetralogy of Fallot, it is recommended that patients have physical examination, electrocardiograms, echocardiograms, and Holter monitoring to look for evidence of increasing right ventricular size, decreasing right ventricular function, and increasing QRS duration. Those patients with increasing right ventricular size and increasing QRS duration may be candidates for pulmonic valve replacement before the QRS reaches 180 milliseconds. Listen once again to the combined murmurs of subpulmonic stenosis and pulmonic insufficiency. In summary, Tetralogy of Fallot continues to be a problem for many adult patients with congenital heart disease. The greatest long-term risk for patients with repaired Tetralogy of Fallot is ventricular tachycardia and sudden death. The presence of ongoing pulmonic insufficiency leads to increasing right ventricular size and increasing QRS duration. When QRS duration reaches 180 milliseconds, patients are at a high risk of ventricular tachycardia and sudden death. Replacement of the pulmonic valve has been shown to lead to stabilization in the QRS duration and may decrease the risk of sudden death. Listen once again to the combined murmurs of subpulmonic stenosis and pulmonic insufficiency.